champions of Asia. It's us, it's Qatar. But we're really excited about hosting the World Cup in 2022 as well. Aspetar is really a collection of incredible clinicians and researchers, and especially Rod and Hans Toll has done a lot for our hamstring research, so I'd just like to acknowledge them. We have a lot of colleagues that work out in the clubs like many of you, so really a lot of this work is possible through this collaboration. But it's an open invitation. If you're ever in the Middle East or traveling through Doha, please stop by and come and visit us. We'll be happy to host you. Right, so why do we care about hamstrings? It's still our number one injury in football. By far the most common muscle injury and overall the most common injury. If you're a team doctor at a club, you can expect about 6 or 7 of the guys in your team to have a hamstring injury every year. Be prepared for. So what do we include in our assessment? I think in the past we were really reliant on recipes. We had a bunch of things we had to tick off the list. There's a bunch of these available on the internet still, but we know that recipes don't work, right? Well, no, our players are all very different and we're different. So if I give the same chef the same recipe, we're going to have different results. And so we have to change the way we approach our assessment of hamstring injuries. And as we were reminded with the World Cup in Russia, not just last year, I mean, so something we have to deal with. And for today then, we'll give a quick overview of our assessment, some thoughts about rehabilitation, and then also just a quick idea or two about our return to sport process. The wait and see approach doesn't work anymore as well. We know that if we're just letting time heal the injury, what we're doing is we're under-preparing the athlete to return to sport. These don't work. And I would say if we start with our purpose, what's the goal of our treatment of hamstring injuries? Or any injury really, I think if we had to put it in one sentence, this would be it, isn't it? Facilitate a timely and safe return to sport. Of course, medical physicians or team doctors, I know you have this in mind as well. We're thinking about re-injury risk, the long-term health of the athlete, the return to sport decision-making and what will influence that. So we have all these things happening in the background. Our initial assessment, I think we still have 3 basic things that we're doing. So of course we observe both the injury and then the function of the player. At what functional level is he at that stage? Can he walk without a limp? Does he have restrictions in his movement? If you're in a fortunate position, then you can also observe the mechanism of injury. So this is the most typical way we always think of hamstring injuries in football. High speed running in a slight change in direction. This video is really great, and I actually can't find it. This is from a physiotherapist at Aspetar, Adam Lallana, making his return for Liverpool after he had a bad groin injury. So he's on the field for 10 minutes and he gets into this awkward tackle, and I mean, maybe he's just a little unlucky, right? But it's in the stretch position and he's having pops. And this is 3 months before the World Cup. This is a big deal. So observing these mechanisms of injury can also influence our rehabilitation. So much research now that if you allow your patient, your player to speak to you, just let them tell you their story. So give them that time. It will save so much time in your diagnosis and assessment. Also use this opportunity to explain and educate the patient that this is not a quick fix, but this is a criteria-based progressive process from physio back to sport-specific activity that will allow them to return to football. Then I think we feel, and I think that's still the big 3. So pain on palpation, we test their range of motion or flexibility, and we test for loss of strength. So these 3 things should really be the cornerstone of your clinical diagnosis. And if you do them well, that's really what you need. That's all you need. So imaging, big question mark. So when we're doing MRI, and I don't have to explain this to you, we're looking for the presence of edema and how much fiber disruption that is, so we can grade the injury, right? MRI is not useful for is predicting return to sport. So we simply we cannot know whether the injury will take longer or not if the extent of MRI disruption is more. But there's good reasons to do them, right? To rule out really severe injuries. If you suspect an proximal avulsion, you need an MRI. If you suspect a central tendon or intramuscular tendon involvement, you need to do an MRI. You cannot know that otherwise. So I submit to your knowledge on this topic. I thought I'd just quickly summarize what, at least for hamstrings, we know about our medical management options. So non-steroidal anti-inflammatory drugs, there is just no evidence anymore that we need to routinely give them. Of course, if you have an excessive inflammatory response, sure, but not routinely. There is no evidence to support that they will speed up the healing process. In fact, perhaps the opposite. Corticosteroids is a for sure no, unless they're on, if they're on steroids for something else, fine, right? But not for the muscle healing. Corneal and actovegin is these alternative options. They really sound good, they sound promising, but we don't have any evidence for them at the moment. And I'll talk about that a little bit more. Stem cells, we don't know much about them in humans yet. And losartan, which was really a cardiac fibrosis measured in hypertensive disease, it looked really promising, but we're not sure yet about that either. It's you, but just as a reminder of how we get to our platelet-rich plasma, right? And that's what we're interested in because we think it will stimulate the healing process with all really nice growth factors, and that's what we need for the process. Controlled trials so far showed us that in amateurs there was really no reason to do PRP. It didn't make a difference. The Malaysian trial did show positive effects, but we know that the physio and the patient were not blinded to the treatment, so we can't really we can't discount the fact that there was some bias in the study. And then the biggest one so far had 3 arms, showed no evidence. So I think, although it still sounds like such a great idea, we just don't have the evidence to back it up. I'm going to keep this short. We'll move on to rehab. These are the 3 things that should be part of any rehab process now. We have good evidence that we should start early. It's got to be a progressive process, and we can individualize them if we measure what we're doing. So in the New England Journal of Medicine just a couple of years ago, Monica Bayer showed that by an early introduction of and I know this is in amateurs, right? But it's good news for us because the early intervention meant that they returned to sports faster. So the message is get to your team physician, get to the physio as soon as possible to start your process. Just as an example then, this is the criteria we use in our rehab process. You might have to adjust it for your setting, but the player has to earn the right to move from one phase to the next. And throughout each phase is the progressive introduction of running at higher and higher and greater intensities. Online, so you're welcome to go and have a look. And then these are the daily assessments we do, and we use this information to determine what that player does in a specific training session. So by doing this, we can really almost the optimal loading program for each training session. It's really easy. If they keep doing better, I don't push them hard enough, so I have to add something. If they drop a little bit, then I know I've done enough, and we need maybe a little bit of recovery. If they stay the same, we keep going. Right? So really importantly now, we get visitors from all over the world, and they often ask us, what is your return to sport tests? Well, really, it starts on the first day we see them, because from that first consultation with the doctor, there is tests that they have to meet to get through our rehab program until they get to the end. The last thing I'll just quickly touch on is shared decision making. Now, this is very difficult in elite football, or in any football maybe, because there's so much pressure for the players to return as soon as possible. But our return to sport process involves this shared decision making, where the athlete, the coach, hopefully, or at least the team doctor, and the treating physio is in the room, and the decision is really made together. The athlete gets an input in how well they feel to return to sport and what kind of risk we're willing to accept. That's my little summary slide for us. Trust your clinical diagnosis, make your rehab an individualized criteria-based progression, and make sure the athlete understands that the return to sport process is a continuum and starts on the first day of rehab. Track and field conference in May. If you know some of your colleagues that might be interested, please direct them here. It promises to be a really, really great conference.